Okay.
There you go.
Hi. Okay, sorry. Well, welcome everyone. I'm Ashley Halderman, current president of the Texas Association of Otolaryngologists, and we're really excited to have you joining us for the latest lecture in our clinical or high yield kind of clinical topic series. And we are um, tonight going to be enjoying improving nasal airway patency and chronic rhinitis using minimally invasive techniques in the office. We've got a really wonderful group of experts who are going to be speaking for us. I'll let them introduce themselves momentarily. Just want to remind everyone that the fall meeting is next weekend in Houston, and we really hope that you're able to attend. We have a really amazing program put together, some great updates from our work with our lobbyist and protecting the interests of otolaryngologists in the state of Texas. And it's just always great to get together and see everyone. So we really hope you're there. And Dr. Ahmed, I'll let you take it over, okay?
Yeah, thank you, Ashley, and thank you for doing such a great job leading this association. And I think you've made some great changes, and honestly, this is a really exciting group. So I would like to, introduce some of my colleagues here I've been very lucky to work with. One of them was actually my direct colleague here in Houston, and one of them was my co-resident when we were at Baylor College of Medicine. So I'd like to start off with introducing Dr. Brian Wang, who is one of our directors of otolaryngology in Houston Methodist in the Sugar Land Hospital. He's always been kind of cutting edge since I've known him in terms of like pushing the boundaries in the office and doing a lot of surgeries and procedures in the office that typically I thought would be done in the operating room. And so he stood out as a great person to kind of like talk today and kind of discuss what he's learned through his 17 years of practice. And he does have a focus in rhinology and sleep surgery as well. And so Dr. Brian Wang will be starting off, and then we'll be talking about minimally invasive septoplasty. And then I also I'm lucky to be able to have Dr. Michael Yim coming from LSU Shreveport. He is the program director there and associate professor. He's also rhinology and skull-based surgery fellowship trained. And again, we were both co-residents together. And I thought Dr. Michael Yim was perfect for this lecture because he actually performs, he's going to be talking about the nasal valve and nasal airway obstruction, and he actually performs open functional rhinoplasties, but he also does the in-office procedures. And so I think his perspective of, when you choose and when you decide to do a specific procedure in the office versus the OR is great, and his expertise in this, and he's had some publications in this area too. So, Dr. Michael Yim is well renowned for this. And so I'm excited to introduce Dr. Michael Yim as well. And then I'm Omar Ahmed. I'm one of the rhinologists at Houston Methodist Hospital. And again, I'm going to be focusing on posterior nasal nerve ablation and posterior nasal nerve neurectomy. And this is kind of an area of interest of mine in terms of research. And I've been trying to kind of push the boundaries, understand the procedure, and try to better the procedure. And so I'll be talking about a lot of the research that we've done at Houston Methodist. So without further ado, I'll have Dr. Brian Wang start off.
All right. Thanks so much, Omar, for that kind introduction. And thank you to TAO and Ashley for allowing us to share our experiences with these procedures and techniques. So as Omar said, I'm based in Sugar Land at Houston Methodist, and I'll be speaking about minimally invasive septoplasty. Okay, next slide. So disclosures, I do some consultancy work for Aaron Medical. Next slide. So nasal airway obstruction, it's a common thing that we see in the ENT office, and Anthony Del Signore and his co-author, Ipatha, in 2000, that last year, looked at a large cohort of patients. These are all ENT patients that showed up for a variety of complaints, and over a third of them, 37.4%, actually qualified for severe extreme nasal airway obstruction using nose scoring. When I talk to my patients, I typically talk to them, when you're specific about the airway as an upstream, midstream, or downstream problem. And when we look at the nose, we could consider that kind of the upstream area. But even within that upstream area, there's multiple levels or stages of obstruction. And, I think in the last several years, especially on the comprehensive ENT side, we have now a better understanding of the internal nasal valve and all the structures and how they affect airflow. The septum, the inferior turbinate. We're now cognizant of septal swell bodies and really the role of the lateral wall in that airflow. So in terms of the septum, everybody knows septoplasty, and there's multiple approaches to that, endonasal versus open versus endoscopic. Next slide. So in terms of minimally invasive techniques, there are two principal ones. The Clarent probably was the first mover on this. And we all know their balloon sinuplasty kind of technique and product. So probably several years ago, they came out with this Relieve-Attract balloon system, and it functions to displace and mobilize bone and cartilage. The second company is Spirair, and they're a relatively new company. They've been out just for a couple of years, and their product and technique is called Septalign, and this is aimed at correcting cartilaginous deflections. Next slide. So patient selection, as with most techniques and surgeries, is really the most important kind of aspect of this. Choosing the right patient, the right procedure for the patient is kind of paramount. So with balloon-assisted septoplasty, we really have to choose these deflections or spurs that are kind of off of the nasal floor, high enough to allow for the balloon to be inserted kind of along the floor against the septum and then against the inferior turbinate. The spur can't be too high because then you don't have anything on the opposite side to kind of abut the balloon and create that pressure and that out-fracturing approach. So typically these spurs and deflections will be lower on the septum in order to achieve that correction. And I have used it in select cases for caudal deflections, which are primarily cartilaginous. And it is a good option when you're considering kind of access to perform other procedures. And I'll show a couple examples later in the presentation. So I typically in office will do these balloon-assisted septoplasties with oral sedation. And I prep the nose kind of in standard septoplasty fashion. So topical sprays with Afrin, lidocaine, tetracaine gel has been invaluable for in office. And I do infiltrate both sides of the septum with lidocaine. So this is a slide looking, showing the Relieve-Attract balloon. The balloon is at the bottom of the screen. And the workhorse balloon is the 16 by 40 millimeter. And I believe the 14 has been used kind of off-label for in pediatric cases, but most ENT surgeons will use the 16 millimeter diameter balloon. And this should be inflated to 8 atmospheres. In some cases, surgeons have used 10 to 12 atmospheres. Okay, and you can kind of see how much expansion is needed, and you kind of adjust your pressure as you dilate. So this is some pictures from a case study, and this is the left nasal cavity. You can see the cartilage deflection to the left with the inferior turbinate, and the deflection is kind of indenting the inferior turbinate. The balloon is then placed along the nasal floor, inferior to the septal spur and against the inferior turbinate. It's then inflated. And you can see the lateralization of the inferior turbinate, that bottom picture. And really that spur is really kind of, there's a portion that is medialized, and there's a portion that is still remaining. And I typically remove those. I make a Killian's incision anterior to that spur, and I'll raise a flap and then resect that spur with forceps, the caudal elevator. And typically I will first on the concave side dilate. And by doing that, you actually mobilize that spur even more. And so once you raise that flap, you'll see that some of the bone has been morselized, and it's a little bit easier to manipulate after you do dilations on both sides. Okay, next slide. So this is just a CT kind of example showing on the left side pre-dilation and on the right side post-dilation. And it looks like they also did a dilation on the contralateral side, on the concave side. As you can see, the inferior turbinate has been pushed laterally. And I don't think they actually resected the spur. I think it's just been literally pushed more immediately and rotated inferiorly. You can see how wide open the nasal airway is on the left side. Next slide. So this was one of my cases I did for caudal, that had a severe caudal deflection. And this was an elderly gentleman who had COPD. And really, his chief complaint was that he couldn't wear his nasal cannula on his right side. He was primarily breathing, this oxygen through the left side. He just wanted to be able to use his nasal cannula on both sides. So, he's a poor surgical candidate, multiple comorbidities, very frail. I think he was on blood thinner. So I told him, I could do this in-office procedure to try to get him some measure of an airway. And so on the picture on the left, we've already prepped the nose, and I've placed the balloon catheter as low as I can. It was a little tough, so as low as I can on the nasal floor, trying to traverse the deflection with the balloon. Inflated, and you do hold it for 2 minutes, and then after which you deflate it and remove the catheter. And so you can see on the right, it looks amazing. There is, when you do caudal deflections, again, we're primarily cartilaginous, you do get some rebound of that cartilage. And so I would say it's probably half of what you see there now. But still, ultimately, he had at least 3-4 millimeters of airway, so which he could place his nasal cannula prong through. So he's been very happy with that result. The second case was very similar. It was a lady who had a deflection to the opposite side, very poor health, tons of comorbidities, not a good surgical candidate, but a chronic pseudomonal infection. She had pretty stocked in left maxillary sinus that was filled with pseudomonas and pseudomonal debris. And, we had done multiple cultures, tried oral antibiotics, and then finally I said, look, we really have to try to open this. But the access was so poor because of her septal deflection that was caudal. So, I ballooned it, and this was the case of, you balloon it, and then the other side closes off, and you balloon the contralateral side, the normal side. And so I was like pushing the septum a little bit back and forth, and I had to kind of just finagle it and get it to the point where the good side was not too closed off, and then the affected side was still patent. So I was able to do the enterostomy, and I just actually saw her today, and her maxis looks completely clear. There's no sign of pseudomonal debris. She's been able to use topical nebulized antibiotics very successfully, and is very happy. And this has helped her lower airway disease as well, like a chronic cough. So those are two cases in which caudal deflections were able to be displaced in order for access reasons, and provide some comfort of breathing. So the next kind of innovative septoplasty technique is this, I call it the suture suspension technique. And really it's this anchored suture that is placed across the convexity of the deflection. It's very simple and elegant in its design. You tighten the suture across the convexity, and then it will heal. And the cartilage remodels in several weeks, and this PDS implant suture is fully resorbed within 6 months. So you can see the handpiece in the right side, and then that suture type anchor below it. So the next slide is a little bit more of a schematic showing the actual technique. You make a mucosal flap on the side of the convexity. You place the handpiece kind of proximal to the convexity. You deploy the implant anchor across the cartilage and through the mucosa on the contralateral side. Then you pull out the suture and then expose that distal end of the suture. And you pass that through the point that is on the other side of the convexity, so distal to the convexity. And then pulling that suture tight until that convexity is straightened. And then you trim off that end and then lay your mucosal flap back. And then you can close that incision if you like, or you can leave it to heal a secondary intent. So that's the suture suspension septoplastic technique. And they've proven this scientifically looking at the histology, and this is in animal studies. And you can see in the far left at 2 weeks, the mucosa, the PDS, suture anchor, the cartilage, and then the mucosa is on the deep side, which you can't see on the histology part. But by 5 weeks, you start to get some cartilage remodeling. And then at 10 weeks, you start to see the PDS reabsorption. And about 15 weeks, which is about 4 months, you start to see remodeling, and that PDS has now been incorporated into the cartilage. So that is the minimally invasive septoplasty techniques. And I guess we can reserve questions for the end, and there's my email.
Guess I'll just go ahead then. Thanks, Brian. All right, hopefully everybody can see my screen okay. Okay, thank you, Omar, for that introduction. Again, I'm Michael Yim, program director at LSU. And as Omar mentioned, even though I'm a rhinologist, I do a fair amount of functional rhinoplasty. And so I'll try to hopefully give some insight into how I like to think about the nasal valve. I'm also a consultant for Aaron. I want to first start off this portion by defining what exactly is the nasal valve. So we know that you've got your internal valves, you've got your external valves. Your external valves are going to be made up of your sill, your alar rim, and your columella. And then when you think about the internal nasal valve, it's classically the nasal septum, or the anterior portion of the septal swell body, the caudal edge of the upper lateral cartilage, and then the head of the inferior turbinate. And this triangular space that's in between these three things that we typically refer to as the internal nasal valve. Now, when we start talking about nasal valve collapse, however, really we're not talking about the septum or the turbinate anymore. We're just talking about the caudal edge of the upper lateral cartilage. And it's actually even beyond that, because once we start talking about static collapse, dynamic collapse, really what we're referring to is the entire lateral wall of the nose. And so I think when we talk about the nasal valve, it's really important to distinguish, is it internal versus external? Are we talking about the cross-sectional area of the internal nasal valve, or are we talking about the lateral wall and how much it's collapsing in? When you look at computational fluid dynamic models of nasal airflow through the nose, we know that the vast majority of the airflow goes through the internal nasal valve. It goes up and over the head of the inferior turbinate through that area of the internal nasal valve, and it goes posteriorly. Here's another study that was published 3 years ago in a physics journal looking at the magnitude of velocity through the nose. Anterior is on the right, posterior is on the left. When you look, here's the outline of the nose. You can see the nostril here, nasopharynx is back here. As the airflow comes in through the nose, you can see that the maximal velocity is picking up through that internal nasal valve area. When you look at an axial cross-section, this is a top-down look. Again, anterior is over here, posterior is over here, left and right nostril. Again, right at that pinched internal nasal valve area, the head of the inferior turbinate, the septum, that lateral nasal wall, that's where the velocity is going to be the highest. Harkening back to all of our otolaryngology written board days and Poiseuille's law, just a quick reminder, the flow rate is equals to pi multiplied by the pressure difference multiplied by radius to the 4th power over 8 times viscosity times length. So, what does this actually mean? I like to think about this in hard numbers. So if you think about the original flow rate as, let's just say 100 centimeters cubed per second, if you double the length of the tube, the flow rate is going to drop in half into 50. And you look at the equation flow rate, its inverse relationship to viscosity and length. And intuitively, this makes sense. You make the tube double the length, the flow rate is going to drop in half. You double the viscosity, so let's say you go from water to honey or something, the flow rate is again going to drop in half. And again, intuitively, it just makes sense. What happens if you double the pressure? Well, then proportionally, the flow is also going to double. And again, that intuitively makes sense. What happens if you double the radius? Whoa, okay, so now we've gone from 100 flow to 1600. And so I think when you put it into hard numbers, it really gives you an idea of just how drastically you can change the flow if you change the radius. What does that mean for the nasal valve and nasal obstruction? If you increase the radius by 20%, you can double the flow rate. So when I look at a patient and I look at their internal nasal valve and I look at their nasal airway obstruction and I think, can I increase this patient's nasal airway by 20%? Yeah, almost always. I really rarely ever see a nasal airway obstruction patient that comes to see me that I don't think that I can increase their the cross-sectional area, that radius, by 20%. And if you do that by 20%, you're doubling the flow rate. And so if you contextualize it to the patient in that sense, and you say, hey, listen, I could probably double your nasal airflow, most patients will probably want to go for some intervention. All right, So now we're going to shift gears to Bernoulli's effect. So how does this come into play? I think it's really important to evaluate patients pre-decongestion and post-decongestion and comparing those two exams. So before you spray your patient with your concoction of Afrin lidocaine or whatever it is you're using in your practice, doing a modified caudal, looking at the turbinate, looking at how big the turbinate is, and maybe even the swell body, decongesting the patient, and then doing a repeat post-decongestant exam, looking at how much did that turbinate shrivel down, and now how much are you seeing benefit with that modified caudal exam? Why does that matter pre and post decongestion? And this is where that Bernoulli's effect comes into play. And just as a quick reminder, the Bernoulli effect is as the fluid speed increases, you get a concurrent reduction in pressure. And that's depicted here. So as the flow velocity increases, the pressure is decreasing. What does that mean for the nose? As the flow increases through the nose, after you decongest a patient, you will have increased negative pressure generation inside their nose. What does that mean? If the patient is supremely congested at baseline, you probably will miss or underappreciate dynamic nasal valve collapse. And so the importance of evaluating these patients pre and post is that you may have a patient who doesn't really have dynamic nasal valve collapse. You decongest them, and now all of a sudden they've got this increased flow. Subsequently, they have more negative pressure generation, and subsequently they are having more dynamic valve collapse. So as far as options to address internal nasal valve collapse or stenosis, this is my stepwise ladder and how I like to think about it. So you go from the in-office, Latera or Vivere, and then the next step is the minimally invasive surgery or endonasal batten grafts. And then again, I do a fair amount of functional rhinoplasty in my practice. Once you open the nose, then you have all of the options available to you. You can do spreaders, you can do battens, you can do flares, you can do auto spreaders, et cetera, et cetera. For purposes of this talk, I do want to focus on the first two categories. And I do want to emphasize that neither of these options, I think, precludes a patient for eventually having a full rhinoplasty in the future. And I say that because I talked to a number of general ENTs who they're worried about doing Latera or Rivere, or even an endonasal batten because they're worried about the effects of what that might do to the patient and getting a rhinoplasty down the road. And I just don't think you burn any bridges if you approach it from this perspective. Latera, for those of you who have not seen this yet, it's been on the market probably for about 7-8 years now. It's a dissolvable PLLA implant. It comes in this trocar that looks like a really big needle, and essentially you insert it into the nose on top or superficial to the nasal cartilages, and the implant anchors off the nasal bones, and essentially you're trying to stiffen the sidewall of the nose with this implant. When you look at published literature, Latera has been shown to be effective with sustained results greater than a year. So this was a CIS review and meta-analysis published in IFAR. 400 patients showed that up to a year out, they found significantly reduced lateral wall mobility and persistent nose score, a decrease in nose score. Unfortunately, Latera has also been associated with some complications. And so this was published by Pete Manez and his group. And they looked at the MAUD database, which is it's the manufacturer database. And there were 26 device reports that were submitted over the course of 6 years, 13 abscesses, 5 implant protrusions. And then looking at the group greater than 1 year post-implant, 3 persistently had a failure to absorb, and then there were another 3 patients with facial pain and discomfort. Now, I will say that Stricker says that it can take up to 18 months for this implant to absorb, so I don't know how many of these 3 patients were still within that 18-month window, but I think this just gives you an idea that this implant can potentially have some complications. Shifting gears to Vivere, for those of you who have not seen this before, this is what the Vivere console looks like. Vivere is essentially a temperature-controlled radiofrequency method of stiffening the nasal wall, and that's what it was originally designed for, and this is what the tines look like. This is what the procedure looks like. The one reason why I really like Vivere is that even though it was originally designed to address that lateral nasal wall, you can actually also use it for the septum / the septal swell body, as well as the inferior turbinate, and this is what that looks like in practice. And so here's a video of that Vivere wand starting off on that septal swell body, and then moving on to the inferior turbinates, and that the wand is stiff enough that you can actually aggressively outfracture the inferior turbinate and get a really nice outfracture at the same time. And then following some local injection to the that nasal valve area, that lateral nasal wall, treating that. So, it's a nice device that you can address all three components of that internal nasal valve pretty well. Anesthesia can be tricky. I think the key point here is the injection. Early on, when I first started doing this procedure in clinic, a fair amount of patients still felt, I think the heat coming through is what it was. And initially, early on, I was only infiltrating on the mucosal side. I have now changed my technique. I infiltrate both the mucosal side, and then I advance my needle through until I start seeing blanching on the external skin. And I think what was happening early on is that the device goes up to 60 degrees Celsius, and I think patients were feeling that heat transmit through all the way into the skin. And so now that I've been anesthetizing both the internal lining as well as the external skin, my patients have tolerated this procedure perfectly. And so here's another example of the pre and post. So here's the patient's left side. You can see that there's some significant static valve collapse. The lateral nasal wall is almost sitting on the septum. And then post-procedure, as well as 3-month post-op, you can see the improvement in nose scores. And then looking at the right side, again, very similarly, static predominantly, as well as some dynamic collapse. And then immediately post-procedure, the improved patency in that airway, and then 3 months out. When you look at the literature, you can have results that are sustained up to at least 4 years. This was a study that was published in the IFAR, and they found that they had a 96% no score responder rate, as well as an average 68% reduction in no scores. And you can just see the nice reduction in no scores over the years. This was a study that I published. This was a systematic review and meta-analysis that I was a co-author on. And essentially, we looked at all published Vivere studies, essentially, temperature-controlled radiofrequency, that's TCRF, and we compared it to functional rhinoplasty literature. So 275 Vivere patients compared to over 2,000 functional rhinoplasty patients. We looked at the weighted mean difference of their nose scores pre-procedure and 1 year post-procedure. And you can see essentially that the results are very equivocal. When you looked at functional rhinoplasty patients who only had their nasal valves addressed, so these were patients who basically got a rhinoplasty to either have spreaders or battens placed, 232 patients, the scores are similar. And when you look at patients who did not have their turbinates treated, just the valves only, again, similar results across the board. And so, even though I was a co-author on this study, and we published this, I will say that as somebody who does a fair amount of both Vivere and functional rhinoplasty in my practice, I do not necessarily consider them to be equivalent procedures. At least in my hands and in my practice, the gold standard will always be the functional rhinoplasty as far as getting definitive outcomes. But what I will say is that what this study did was really open my eyes to the efficacy that you can potentially get with Vivere. And I've had a handful of patients similar to a patient that Brian presented earlier, where you get older patients, a lot of comorbidities, they're not necessarily good surgical candidates. Vivere has become a really good option for these patients. And I think over time, my threshold to offer Vivere to patients has become less and less. And very quickly, with the time that I have left, I think endonasal batten grafts are a good surgical option that should be in the repertoire of all general otolaryngologists, even if you're somebody who doesn't do functional rhinoplasty. I think an endonasal batten graft is something that is very simple to do, and it's something that I train all my residents to do as well. And essentially, all that is you make an incision right at that caudal edge of the lower lateral cartilage. You dissect a tight pocket over that cartilage and out laterally to the piriform aperture. You feel the bone of the maxilla with the tip of your scissors, and then all you have to do after that is just insert a piece of cartilage, either harvested from the septum or the conchal cartilage as a graft. And so I think this endonasal batten graft is a really nice intermediate option that you can potentially have in your arsenal without either signing these patients up for a functional rhinoplasty or referring them out to your facial plastics colleagues. So just to summarize my take-home points, as we saw with all those physics studies, a problem with nasal obstruction is most likely a problem with the nasal valve. I think defining the nasal valve really helps to guide your treatment. So what exactly is the problem? Is it internal nasal valve narrowing? which means, is it a combination of the septum or the turbinate and the lateral wall that are all contributing to the problem? Or is it dynamic nasal valve collapse, in which case you should probably think about what can you do to strengthen a weak lateral wall? Is it static collapse, in which case, maybe you need to think about repositioning the lateral wall. I think it's really important to have a high degree of suspicion for nasal valve collapse, and the easiest way to do that is evaluating patients pre and post decongestion. And again, just thinking about things in a stepwise fashion, I do think these in-office procedures and the endonasal batten is a really nice intermediate step prior to committing a patient to a full rhinoplasty. Thank you so much. That's my direct email address. For those of you who are in practice in Dallas, Jen Dang was a co-resident of mine that I graduated with. And then for those of you who are around in Houston and you know Rachel Ragoni Yao, another co-resident of mine, so tell them I say hi. And then these are my kids, and they're very excited for Halloween coming up next week. So thank you to TAO and to Dr. Ahmed for having me on.
So, thank you, Mikey. And I'll switch gears here and open my presentation. Let's see. Let me share my screen. All right, could you guys see my screen? Okay. Are you guys able to see my screen? Just wanted to confirm.
Yeah, looks good. Omar.
Yes.
Okay, cool. Awesome. So I'm going to talk about the evolution of in-office treatments for chronic rhinitis. This area I'm particularly interested, especially in the research realm. So I am a consultant from Medtronic and Aaron Medical. So when we're talking about chronic rhinitis, this is a very, very common disease process that affects millions of Americans, right? There's these numbers from 2001, right? So 30 million non-allergic rhinitis patients in the U.S. and 60 million allergic rhinitis patients in the U.S. About a fifth of them are refractory to any medical treatment, and only a third of them felt mild to moderate relief from medical therapy. So most often, when patients come to see you, they've often tried medical therapies and they're looking for something else. This has a significant effect on overall quality of life. About a fourth of patients with chronic rhinitis have trouble sleeping, secondary rhinitis symptoms. There's associations with increased rates of depression, anxiety, decreased work productivity, and 50% of patients report effect on daily life. So when we think about chronic rhinitis, right, this is a big diagnosis. But it's actually many diagnoses lumped into one big diagnosis. And so, when you think of there's infectious rhinitis, there's allergic rhinitis, oftentimes mixed rhinitis, and then there's non-allergic rhinitis, which is a lot of these other rhinitis, which we know, which is, gustatory rhinitis, drug-induced rhinitis, idiopathic rhinitis. And so again, this is a big disease process, and we all kind of lump it in one, but there's actually many different causes that can trigger inflammation in the nasal cavity. So for example, this is a patient with, vasomotor rhinitis with postnasal drip. And when you look on endoscopy, you can see here, this is not much inflammation elsewhere, but they just have this constant postnasal drip on scope. And I did a flex scope because they're having postnasal drip. And again, you can see there's a lot of drainage posteriorly, but all coming from the nose. This is an allergic rhinitis patient. You can see the classic blue boggy turbinates, this tissues all edematous, and this patient tested positive for significant environmental allergens. Then we have this patient has, looks like CRS with polyps, but actually, when you get a CT scan, there's no CRS. They just have significant polypoid changes in this nasal cavity along the middle turbinate. And so this patient has CCAD, central compartment atopic disease. So again, these are all different forms of rhinitis, but all kind of lumped in the chronic rhinitis group. Again, in terms of medical therapies, these are the, I'm not going to go into the details of medical therapies, but you oftentimes first try medical therapies, whether it's ipratropium bromide, nasal steroid sprays, nasal steroid rinses. And then for allergic rhinitis, there's these therapies as well, which oftentimes overlap. So I'm going to talk about kind of more the evolution of our surgery. So the role of the Vidian nerve and the posterior nasal nerve is known that whatever rhinitis is occurring, a lot of the symptoms are oftentimes partially driven by overactivity of the parasympathetic nervous system in the nasal cavity. And this occurs in both non-allergic rhinitis and allergic rhinitis. And it's shown that when you actually disrupt the Vidian nerve or the posterior nasal nerves, it actually helps with reducing vasodilation and it decreases blood flow to the tissue in the sinonasal cavities. And there's decrease in drainage. So this is a study in 1959 where they actually stimulated the Vidian nerve in a cat. And they found that stimulation led to increased congestion and also increased nasal drainage. This is in 1959. In 1961, the first Vidian neurectomy was described, where they actually went through a Caldwell-Luck incision all the way to the Vidian nerve through the maxillary sinus, and they found significant improvement in a lot of symptoms. Can you imagine doing this without endoscope and microscope? It's quite challenging, but they're able to actually get this, and they found success. So this is the first Vidian neurectomy. One of the questions we had is in the terms of the Vidian canal size, right? Is a Vidian nerve bigger in these patients with overactivation? You would assume so, but what we found when we actually measured patients with rhinitis, we found that the actual Vidian canal diameter was smaller, and so maybe there's some type of compressive effect. So then we go kind of through the evolution, right? They started with Vidian neurectomy, did these transpalatal approaches, then they did transnasal transeptal approaches, then they did microscopic approaches in the 1980s, to endoscopic transnasal approaches in the 1990s and 2000s, and we still do them. And then kind of shifted gears to selective posterior nasal neurectomies, where instead of getting the Vidian nerve, we get the selective branches in the 2000s. And it's been popularized, and I still do quite a few of them, to the in-office posterior nasal nerve ablations, which were FDA approved in 2017 with Clarifix, in 2019 with Rynair, and in 2022 with the Neuromark device. And so I'm going to just show you this quick posterior nasal neurectomy, and this helps kind of doing these surgeries itself helps you understand where these posterior nasal nerves are coming out, right? So this is like an incision for you do for a sphenopalatine artery ligation. You see all these branches, and then as you go, there's the sphenopalatine artery, which I'm going to clip here. I'm just isolating the artery, but look at all these branches all along the wall here, near the attachment of the middle turbinate, lateral wall attachment, and then you go further back, and you see all these other small branches, and you see all these nerves, and that's pterygopalatine fossa up here with the fat sticking out. And so these are all these nerves that, technically are leading to overactivation of the parasympathetic nervous system. So overall, selective posterior nasal neurectomy is very effective for both allergic and non-allergic rhinitis. The improvement in response rates anywhere from 88 to 96%, and there's minimal complications. And it's effective for even patients with refractory allergic rhinitis. This is a nice meta-analysis, which shows that it was effective in even patients with CRS with nasal polyps, right? So clearly decreasing the parasympathetic nervous system is helpful. Now I'm going to kind of go into the actual 3 specific devices that have been FDA approved. So how do you decide, which patients to actually do these procedures on, right? And I think in the era of these minimally invasive techniques, I think that doing the minimally invasive techniques are first line now versus doing the surgeries. And that's because they're, again, minimally invasive, less harm to the patient, and they can be done in clinic. And so I think about patients, I give all my patients a TNSS scoring system, and the score greater than 6 on the scoring system, I think that they have at least moderate to severe symptoms, and they've had to have failed medical therapy. What about atropine response? Do you use this as a screening criteria? I think atropine response is a good predictor for anterior rhinorrhea, for the symptom of anterior rhinorrhea. So if a patient has a good response to atropine, there's a higher likelihood that they would benefit from one of these posterior nasal nerve procedures in clinic, but only for the symptom of anterior rhinorrhea. The symptom of congestion, drainage, postnasal drip, it doesn't really predict that. What about allergic rhinitis? Is this effective for allergic rhinitis patients? Is it effective for postnasal drip patients? So we did a trial best practice paper several years ago looking at, allergic rhinitis and looking at the evidence, and there's definitely overwhelming evidence that posterior nasal nerve ablation is effective for allergic rhinitis. What about postnasal drip? And so we looked at all postnasal drip patients who had chronic rhinitis, and we found that postnasal drip scores significantly reduced, even chronic cough scores. And these were patients who had postnasal nerve ablation for chronic rhinitis. And again, these symptoms improved. We also looked at our own data of patients who had the primary symptom was postnasal drip, and the other symptoms were not as significant, and that's including nasal congestion, and their primary symptom of postnasal drip. And these patients, postnasal drip is its own bag of worms, can of worms, but it's it can be a lot of different causes, right? It can be reflux, it can be like a sensory phenomenon. But patients who we've basically tried everything else, right? They've gone to GI, they've gone to laryngology, they've tried every therapy, and they don't know what else to do. A lot of the times the laryngologist sent the patients to me and my colleague, Dr. Takashima, and we actually offered postnasal nerve ablation. And we looked at our results. Again, single arm study, and then 72% of patients said they got a 30% improvement at 6 months. And so clearly there's a role. And my question is, a lot of people ask me that this doesn't make sense. Postnasal drip is so confusing. And part of me is thinking that maybe there's some sensory nerves in the postnasal nerve region that we're also ablating, and maybe it's helping in some way. The first device that was FDA approved in 2017 is Clarifix. Again, this is cryotherapy of the postnasal nerve, and it freezes the nerve anywhere from -20 to -60 degrees Celsius. There's some great data in terms of efficacy all the way past 6 months here in the systematic review, where the TNSS score decreases and is persistently decreased. And the response rates are quite good, anywhere from 60 to 80%. So this is a procedure I did Clarifix on. Again, I'm sure a lot of you have done this. I always inject for Clarifix because of the risk of ice cream headaches. And so I always inject. I use a RAN needle that's easy to inject with. And then again, I do 2 locations for the treatment. So I'll do one right in front of the attachment. And then the second one, I'll go a little further posterior, especially and along the posterior aspect of the inferior turbinate as well. And I'll do that second treatment. And again, the one thing I found with this procedure, though, is that when we actually looked at our headache rate or severe headache rate for these patients, when we looked at we actually called all our patients the day after procedure, and we found that 58% of our patients had moderate severe headache within 3 hours procedure. So the literature shows about 25%, but we did the injection, we put Tetragain, and I think a lot of times if you don't ask for it and you don't call them the day after, they usually oftentimes won't get the headache right when they're in the office, but they'll go home and then complain of a severe headache. So there's some evidence that gabapentin does help with that headache. Now we're going to switch gears to the Rhinair. This is temperature controlled. Again, it heats it to 60 degrees Celsius, and it was FDA approved in 2019. And again, you do several treatments to the posterior nasal nerve region, and then 4 to 5 treatments in the inferior turbinate as well. Again, a lot of good data. This is systematic review. When we pull all the data, there's significant reduction in TNSS, and then the responder rate's about 77 to 80% in the patients at 6 months. There's even 2-year data now for this. You can even use this device in the vibrator to treat the septal swell body, which is oftentimes enlarged in allergic rhinitis patients. So here's a Rhinair procedure I did. Again, kind of septal deviation, tough to get in. So then I use a Goldman. I'm struggling a little bit to visualize, so then I'll use a Goldman to lateralize the turbinate. And then again, this is a patient who failed Clarifix, so then I offer them Rhinair. And then what I'll do is actually go behind the middle turbinate attachment, because there's a lot of posterior nasal nerves in this region. You can see the previous Clarifix procedure. And then again, I like to treat the inferior turbinate because there are a lot of parasympathetic nerves in there as well. Again, this is behind the middle turbinate, and this is the inferior turbinate here. So again, when we actually compare, like, what's better, Clarifix or Rhinair? And we actually did indirect comparison looking at the data that's published. Again, we found no difference in TNSS. One of the things we found is that our results were showing initially about 60% efficacy of responder rate from our real life data. And so we took a lot of these patients back for video neurectomy, posterior nasal neurectomy. And what we found is that the patients who failed and we took back to the OR, their middle turbinate attachments were much more anterior. And so what I'm going to show you here is this: they had unfavorable middle turbinate attachments. If you look on this coronal scan, or the axial scan, you see the middle turbinate attachment is much anterior to the sphenopalatine foramen. And so when you treat in front of the middle turbinate attachment, you miss a lot of the main branches. And so we find a lot of our patients who failed oftentimes had unfavorable middle turbinate attachments, and we published this in IFR. Again, this is a nice dissection by Peter Wormwall's group where they look at all these accessory nerves here and again behind the middle turbinate attachment. So we modified our technique and we started treating much more posterior with both Clarifix and Rhinair, and we found a significant improvement in our responder rate, and we published that. And that last device is the Neuromark, was FDA approved in 2021. And this is, again, it uses bipolar radiofrequency ablation. And it has these two ends here, one that goes behind the middle turbinate attachment and one that comes in front. And it can treat up to 20 lesions per treatment. There's a new version of this device that's coming up where you just have one arm. You don't have this double arm here. And that you can use to kind of target your treatments. There's good now single arm studies. I'm actually involved, me and my colleague, Dr. Takshima, are involved in the randomized controlled trial with Neuromark, and we're the PIs on that study. And so we'll having some data coming soon in the next probably year or so. And this, again, about 80% responder rate. And again, what do you expect in terms of complications with postnasal nerve ablation? There's oftentimes bleeding, crusting, congestion for 1 week. And 2 to 6 weeks, it takes time to see improvement because it takes time for the healing. And then in terms of headaches, we talked about that. And sometimes gabapentin may help decrease the headaches, especially with Clarifix. One thing is we looked at, sometimes these epistaxis that occur after postnasal nerve ablation can be quite scary because they're on the sphenopalatine area. And what we looked, and we pulled all our data from 3 different institutions, about 461 patients. We looked at what's the real life epistaxis rate, and we found about 2.54% of patients had severe epistaxis, and it occurred about 20 days after the procedure. And there are similar rates regardless of the device. And we think possibly there's a pseudoaneurysm, the branches of the SPA that basically kind of rupture at 3 weeks post-treatment. So again, this is one of the complications. So kind of conclusions, with advances in technology, the first option for PNN ablation is in-office PNN ablation, where there's great success rates. Again, you consider this both in non-allergic and allergic rhinitis patients. I think that if patients are intolerant for in-office procedures or not responsive to medication, I would consider surgical procedure options. So if I'm going to the operating room, I oftentimes will just offer a posterior nasal neurectomy. Like if I'm doing a septoplasty, instead of using the in-office device, I think it's much cheaper as well to just do the posterior nasal neurectomy in the OR. So if I'm in the clinic, I'm doing the in-office, the PNN ablation techniques we talked about. But if I'm in the OR, I'm oftentimes doing a selective neurectomy. Again, thank you to one of my colleagues, Dr. Mas Takashima, Dr. Brian Wang, and Dr. Michael Yim.